Good afternoon, everybody. I don't know if you can see me. My computer just froze at a very untimely moment, but hopefully you can hear me. If you could let me know. Apologies, everybody. My name is April Masson. I'm the portfolio lead for primary care, and I'm going to be kicking us off this afternoon. I had a bit of a freeze there. It always happens at the wrong time, doesn't it? So welcome everybody. I am delighted to welcome you to this 9th webinar in our resilience series, which is focusing today on improving access to general practice. We plan and co-host these seminars with our colleagues in Scottish Government, NES and the Royal College of GPs. And today we're going to have several speakers sharing what they've learned from their efforts to improve the quality of various aspects of GP access. So it's brilliant to be here today, and this is the first time I've attended one of these, so fantastic. If I could have the next slide, please. I just want to cover a couple of housekeeping items just very, very briefly before we get started. I know everybody's well used to Teams by now. So firstly, we would just want to encourage everybody to use the chat to share your thoughts and any questions that you might have throughout the session. So if you know how to click on the right and access the chat box, you can do that. We are going to have facilitators throughout the session, the first and the second session, sort of pulling out any questions or comments that might be relevant. So if you want to upvote those, you can just click the thumbs up, and that sort of shows that you want to hear more about those questions. So you'll notice that your cameras and mics are automatically switched off, and that's just to prevent noise and distractions. If people do want to come into any of the discussions at any point, we can unmute you centrally, but just remember if that happens that you'll also need to unmute yourself as well when the time comes. And then finally, if you do, or when you do need to leave the meeting at the end, you'll use the red leave button. And if, like me, you sometimes accidentally click that mid-flow, don't worry, you can use the same link to get back in that you came in on the first time. Next slide, please. So we are recording today's session, and you'll be able to access this recording as well as other recordings that we've done throughout the webinars by visiting our website, and I can give you details of that right at the end of the session. Next slide, please. So the purpose of the series of webinars hasn't really changed over this time. It's really to provide opportunities to connect with peers and reflect on learning and discuss current issues within primary care. The first part of the webinar is going to focus on improving access from a patient's perspective, and our chair and facilitator for that session will be Dr. Michelle Watts, who's a senior medical advisor for Scottish Government. And the second part of the session is going to focus on times to accessing care, and our chair for that session is going to be Dr. Scott Jameson, who is a GP in Tayside. Next slide, please. So when we think about access, we tend to think about it in sort of two different ways, or from two different perspectives. The first one is around improving equality of access. And this is really about making sure that particular groups aren't excluded from accessing services. And when we are improving access, sometimes there's a risk that we can actually widen the gap for people. So making it more easy for people who already find it fairly easy to access services. So we want to make sure that we don't widen that gap. And then the second element of access is improving, obviously, the time it takes for people to receive care. This is influenced by demand, capacity, and activity. And if you're familiar with some of the work of the portfolio, you'll be familiar with some of the tools that we've shared to work on that. So by exploring where these challenges lie, we can identify tools that we can use to address these different challenges. So maybe using care navigation or workflow optimization to help us look at those different things. So that's what our session today is going to focus on, those two aspects of access. And I'm now going to hand you over to Michelle, who's going to lead us through the first session. Over to you, Michelle.
Thanks, April, and a very warm welcome to everybody. It's great to see so many people arriving, and please do keep that chat bar coming. Questions, comments, sharing of information. I'm going to be your conductor on this first stage of our journey, when we're going to be looking at access from a patient perspective, and we've got some fantastic speakers today. Fiona Duff, who's a colleague of mine at Scottish Government, an advisor, and the lovely Dr. Kate Dawson from Benbecula, and from a patient perspective as well. And Kate's also a brand knitter, so I don't know, Kate, if you're wearing any of your own products today, but it'll be lovely to see you on screen today. So thinking about access from a patient perspective, and before we kick off on what's going to be a really busy session today, I'd just like you just to take a little moment and just think about what access has been like for you over the last couple of years, perhaps as a patient, perhaps as a concerned relative trying to get some information, perhaps as a parent, perhaps as a receptionist who's been on the other side of somebody really upset, perhaps somebody who's been in hospital. Just think what it was like for you. It's really complex, and for some people it's been a really straightforward experience, and for many people it's been a really frustrating and difficult experience. Show me next slide, please. And so perhaps as we're talking about access and improving it for everybody today, I wanted to share the concept, the metaphor of the Norman door. And Don Norman was a chap who wrote a book called The Design of Everyday Things. And the idea about a Norman door, and again, you probably all remembered doors where you've not been quite sure if you open it, you push it, you pull it, where the handle is. But it's any door that's difficult or confusing to use. When you try and open that door, does it make sense to use it? Pushing versus pulling, how did it really make you feel? And actually, how do we make sure that the door is open and accessible for people, not just who are able to push it and pull it, but who need it most? So I'm really hoping some of these principles and this metaphor of the Norman door will kind of resonate with you as we go through today's presentations. They're going to be pretty fast paced. Please post questions in the chat bar, and we'll have some time for discussion. But without further ado, I'm going to pass you on to Fiona Duff around managing access to general practice and primary care services in our post-recovery scenario. So over to you, Fiona. Thank you.
Hi, can you all see and hear me? Yeah. I'm assuming that's working. So yeah, I see a thumbs up. Thanks everybody. Right, I'm going to rattle through this really quickly. And my apologies to anybody that's heard me speak recently at some practice managers events. You might have heard some of this before, but I think it's really important and worth going over. So those of you that don't know me, my name's Fiona Duff. I'm a senior advisor to the Primary Care Director at Scottish Government, working closely with Michelle and others. And my background is in primary care and practice management. And today I'm just very quickly going to go over some of the issues around access and some of the things that we're thinking about doing to kind of support it. So can I have my next slide, please? Thanks. So I think the picture is what the public thinks at the moment. This is, if you read the Mail online or you go on social media, these are the things that we're hearing about at the moment. The perception that patients is finding it difficult to access the care they want and need, and that's one of the questions, is about want or need, but that there's difficulties accessing care. But we're in a transitional period, we're in a recovery period at the moment, and things are changing. And there's a number of things that we need to think about. And what will the new normal look like? What will it look like as we're coming out of this pandemic? We've had 2 years of working completely differently, hybrid working, and what is going to stay in this new way of working? How much face-to-face appointments are we going to move back to? Telephone consultations, I think, are here to stay, but how will they look? Are we going to keep triaging? I know many practices have moved to triage in the last 2 years. Some love it, some hate it, some have stopped doing it. Some feel that it creates double handling of work. What does your practice think about it? Are you going to continue using it or not? Or are you going to move to a more patient-friendly, maybe realistic medicine approach of giving patients a choice of appointments, whether it's a face-to-face or a telephone consultation? And we're getting more and more examples of practices who have done that and reduced that double handling and actually are not being overwhelmed with demand and face-to-face appointments requests. So how do we manage that as we come out of the pandemic? How do we continue to work in this multidisciplinary way with the increased number of different clinicians working with the practice and move away from a GP focused way of working to a general practice multidisciplinary team way of working? And how do we bring the public with us on that? Infection prevention control has been really important in the last 2 years, and you are currently all still working to the winter guidance, the respiratory screening and so on. Just to say that will be changing from the 11th of July, we'll be reverting back to the National Infection Prevention Control Manual. I always struggle to say that. And there will be information coming out in the next couple of weeks around what the new normal and the new business as usual around infection prevention control will look like for you in your practice. We're working with our high and we're working with NES in particular in order to take that guidance and share that with you so you've got it in a simple, straightforward way of exactly what it is you need to do, and also what information to share with the public around what will continue to be required around things like face coverings and so on. So we will get that information out to you. NES are now producing a very useful weekly practice managers newsletter on Sway, which is really easy to skim through and see what's happening, what's changing. So I would recommend, particularly if you're a practice manager and you're not on a distribution list from your local coordinator, that you look at that regularly, and all of the information about the changes that are coming will be included in that. As we know, demand's increasing, we've got increasing sustainability issues, and as Michelle said, we've got an increase in complexity and increasing variation out there. If we struggle to manoeuvre through the system and identify where the right place to go when is, then how are our patients and our public, particularly those with particular challenge? I'm sandwich generation, I've got grandkids and I've got elderly parents, and at both ends of the spectrum, people struggle to know where to go when and how to access the system. Can I get my next slide, please? So there's a whole range of things that we need to do in order to support the system and improve and make the system accessible, right care, right place, for all of our patients, particularly our patients with health inequality needs. But actually, I think it's important that we do this for everybody. So the first thing we need to look at is our infrastructure and what we're doing to support our infrastructure. The Scottish Government invested £2 million in practice telephone systems last year, so hopefully many of you on the call have benefited from that. At least 30% of GP practices in Scotland benefited from that. Telephony is actually the biggest area that we could get complaints about from patients just getting through on the system, either because practices are limiting the times or have limited number of phone lines, or there's a whole number of reasons patients are finding it difficulty. And if we could do some work to unblock some of that bottleneck, I think the whole patient experience, complaints, some of the grumpiness and violence and aggression we're getting from patients would be dissipated if we could sort out that block. So we're looking at what can we do around that telephony, and now you've got good cloud-based systems in many of your practices. How are you using the information and the data that you're getting from that? We need to look at our digital and data needs. I know some of you have got things like eConsult and Ask My GP. Again, we're looking at that from an on Once for Scotland basis. How can we utilise that? And what are the things that you need in your practice to make that work? Again, anecdotally, the feedback is some of you love it, some of you hate it. Some of you manage to manage your demand with that. Some of them practices, it's just opened up unlimited demands. How do we control that? And then premises is an ongoing issue. Have you got enough space for all of the team that you need? We also need to look at workforce development, and I'm particularly keen that we look at the role of the practice manager and the admin staff. Is receptionist the right name for them and going forward? Is it patient advisor? Is it care navigator? Should we have one title for them across Scotland, or does every practice have a different title, which, to be honest, I think is just confusing the public? Some of you will be coming to a workshop on Thursday that we're doing with NES, which will start scoping out what we think the role and the training and learning needs are for managers and admin staff in the future. So if you've been invited to that, really encourage you to come to that. As April's already said, we need to look at care navigation. We need to look at our demand and capacity in our practices. And we're starting to have conversations around what are the safe staffing levels we need in practices, both for clinical staff, but I think for admin staff as well. Actually, I think the GP contract has created more work for admin staff. So what are the correct number of receptionists and things do we need? And finally, how do we engage with our patients around all of this? This system has changed so much. So we've got our national public messaging, but also how are you speaking to your, communicating with your patients? How are you using your websites? How are you using your social media and also your patient participation groups? Can I have my next slide, please? And I just want to recommend this receptionist campaign that we run in March. The resources for that are still available if you want to share that with your patients around signposting. I know I've ran way over time, so I'm now going to hand over to Kate, who's going to talk about her work with her patient participation group in the Western Isles. Thanks, Kate.
Hi, everybody. So I'm Dr. Dawson. I'm a GP in Benbecula, which is in the Western Isles. Got a small practice. We've got 2,500 patients and a very close community. So very high levels of trust in the population. And like everybody else, at the beginning of the pandemic, we had to make major changes to the way that we provide appointments. So if you could just move on to the next slide, please. That's a lovely picture of me and an arrow pointing to where the Western Isles for anybody who wasn't sure. And can we move on to the next slide? So at the beginning of the pandemic, we started using our Facebook patient participation group page to share information with the general public about what we were doing. We were also using the radio and the practice website, because obviously no patients into the surgery couldn't use the notice boards in the surgery to put out information. At the beginning of the pandemic, we had maybe about 100 people using the Facebook patient participation group page. And because we had to change very rapidly and the patients couldn't move around, we found that the whole community were using Facebook to communicate about all kinds of things like recipes or sharing music videos that they'd made. So we put all of our information on Facebook as well. And the daily updates on how to access things like online counselling or other resources that you could self-refer to. And it rekindled a lot of interest, and the number of patients registering for our patient participation group just rocketed, currently sitting at about 800 members, which covers most of the practice population households. The Facebook page also allowed dialogue between surgery staff and patients about what services were on offer, and the patients responded by saying, well, actually, we want a proper patient participation group, because it had been very quiet before that. So we reformed and set ourselves up. And if you can move on to the next slide, you can see a lovely picture of a bunch of ladies with short haircuts, all of a certain age. Quite difficult to get engagement from other population groups, but we do have some men and we do have some older people on the PPG. And once we got our constitution sorted out, we started looking at access, because that seemed to be the big issue. What information should we be giving patients about the services in the practice, and what did patients need to know? We looked at a few videos from other practices, mostly of a nice GP explaining to the public how their services had changed. But interestingly, the patients were saying, how do you know that you're giving us the information that we need to know? Are you answering our questions? So if we move on to the next slide, I'll show you how the patient participation group responded. So they put out an access survey, and you kind of think, well, do we not get that nationally? And then I had feedback from my colleagues saying, you're mad. The public, this was at about the time that the public were getting very frustrated about not getting access to the appointments that they wanted. But we went ahead anyway, and we got a really good response. So we had access to this survey was online through the Facebook page, through the practice website, but also anybody calling into the surgery could get a hard copy. It went out for 2 weeks, and it was targeted to the kind of things that we wanted to, the patients wanted to know about the practice. We got 72 responses, the majority of which were online. And if we move on to the next slide, that's a quick summary of the key findings. So they published a 27-page report from the 72 responses, and there were 42 recommendations to the practice about what we could do to improve access to appointments. The majority of responses were hugely supportive of the practice and very grateful that we'd remained accessible throughout the pandemic. The areas where there was a lot of questions were around what the receptionists did and how they worked out what appointments to give to people, and anxieties about the receptionists asking questions about why patients were calling, feeling that that might therefore restrict their options for getting what they wanted. Ambivalence around telephone appointments, so some people saying it gave them better access because they didn't have to travel to the practice, but other people feeling that they were perhaps getting fobbed off and not getting face-to-face with the GP first time. And like some of the people in the chat, we'd had to switch off our online booking. And I would add, actually, around the same time, we also had for a primary care pharmacy and primary care physiotherapy added to what we could offer. So from an economy where if you phoned up, the main thing you were offered was a face-to-face appointment with your GP, there were now 12 options, 4 different professional groups, and all of them either face-to-face, video or telephone. And there was a bit of discussion in the survey as well about how uncomfortable people were about using new technology when they were feeling unwell. So like most people in the chat, mostly using telephone at the time. And so we've got all these recommendations and we need to talk about what we did next. So if we can have the last slide. What we found was the scales fell from our eyes. We thought we were doing very well. We were quite comfortable with what we had on offer to our patients. But actually what we found was that we realised how unsupported our reception and admin staff were feeling, that there wasn't anything explicit out there, that we'd asked them to ask the public about what was wrong with them in order to help them navigate the right appointment, they are now really engaged with using the Health Improvement Scotland Access tool to improve what they can do. We're going to change the telephone, or we have changed the telephone message that patients hear when they phone the practice. And instead of it being the practice manager's voice, it's my voice taking the buck stops with me. I'm the person who's asked the receptionist to ask about why they're calling. And then the other thing that we're going to do, which is a big project and depends on our patient participation group, instead of just having a GP as a talking head, we're going to video Zoom calls where members of the patient participation group interview individual members of staff using the questions and the particular areas that have come up in the report. One of our patient participation group members is an author, so she's going to be doing the scripts for that, just to make sure that all the points are covered. So exciting times and some exciting videos coming out, and a really re-energised approach to improving access to our appointments. That's what I was going to present to you. Happy to answer questions in the chat, and I'm now going to hand you back to Michelle Watts.
Brilliant. Thank you both, Fiona and Kate. And alongside the chat bar, what's really apparent to everybody really is the variation that we're seeing across Scotland, and that some fantastic examples of how things can work really well, but people really clearly articulating a lot of the challenges as well. So picking up from the chat bar, what's quite interesting is that there definitely is an increasing move towards more face-to-face, and it looks as though the majority of you are offering at the very least 50-50 face-to-face and other, most of you looking at up to 70% face-to-face. And I think it's important that we find ways of telling our colleagues out with primary care how much we are doing and returning to normal. Andrew from Alt being Gairloch practice, I like your comment about deciding that the patient themselves, unless they've got respiratory symptoms, and trusting them to know what to do. But also some comments from Guy and around, if you open up too much, then things get swamped and you can't actually see the people who really need to be seen. So there's a real balance, isn't there, to be struck between managing that demand and having completely open access, but then being able to cope with what comes through the door. James, I noted still triage and the importance of that as well. What was also interesting, and just listening to you, Kate, the importance of social media and Facebook, and when it works and it's a force for good, it can be amazing. But I think we've all been party to some of the really painful comments. I think sometimes it can be posted on Facebook, and there's some really quite interesting research around the use of consultations that are digital and how it allows people to perhaps behave in ways that they might do differently if it wasn't face-to-face. But I think we've all got tales to tell of the challenges with irate patients and people upset and frustrated and worried about access. So how do we get a balance there? Communication around other things like websites. Great to see lots of comments in the chat bar there as well. The debate around 10 to 15-minute appointments. Again, there does seem to be a fair amount of variation. But Emma, I think from Grampian, I think you hit it on the head there when you mentioned, really it's about tailoring appointment length to suit the patient. And I know some of the best consultations I had was when we were able to set aside a proper amount of time, invite carers, invite other members of the MDT, and have a real good plan at the end of it. But we can't do that for every patient because we just haven't got the capacity. So I'm going to end today's discussion and I'm going to ask Kate and Fiona. Kate, if you had a magic wand and there was one thing you could do tomorrow, just one thing, what would it be?
Oh, you sprang that on me with no warning, you rat bag. I think probably what we would want is a bigger building. And then everything else would be so much easier. We could have more staff, we could have better telephony, we could be more flexible in the way that we provided appointments. And then after that, I think probably just time to change. So I think we need to manage because we used to have really good control over our appointments, and now we've had to change so quickly. We've lost control a little bit about how we manage supply and demand. And if we got that back a little bit better, I'd probably have more time to manage change.
Yeah, space and time. Thank you. And Fiona, you get the magic wand the next day. What would you change?
I mean, there's lots of things I'd like to change, but my current bugbear is telephone systems and the amount of complaints we're getting from patients who just can't get through. What we hear from patients is the experience once they get through to their receptionist and through to the clinician is really positive. It might not feel like that at your end. The frustration is just getting through to the practice in the first place, and anything we can do to improve that and help with that connection would be great.
Great, thank you, ladies, and thank you very much for today as well. And lots of comments and lots of chat still to come. And I'm going to hand over to Scott for the second part. He's going to be your conductor for the next part of the journey. But please do, if you had a magic wand, what one thing would you change tomorrow? Pop it in the chat bar. Over to you, Scott. Thank you.
Thank you so much, Michelle. That was a really invigorating first half, and I will endeavour to follow in your wake. In this second half, we are going to continue our focus on access, and we will look at some examples from across Scotland. I'm going to start off. Also in this section, we're going to hear from Lynn Martin, practice manager, and Anne Ribbett, also practice manager, but has also done work with Anna's working up in Shetland actually, and she does she's worked in the primary care development session there, and has semi-retired is the way she officially refers to herself. But we really look forward to hearing from their experiences. But I'll start off talking about some issues at the heart of a very topical section here on urgent care. If I could move on to the next slide, please. And again. There we go. Yes, so as you are all aware, we are looking at a wider team to support urgent care, and home visit urgent care is particularly pertinent because it takes a long time to do home visits. So yeah, the kind of time per patient is significantly longer than anything else. But also, I think particularly it's the area that benefits hugely from a vast array of skills beyond that of the expert diagnostics and prescribing that I can provide. People who are not me think about a lot more facets to home visits in urgent care than I do, and I'm really grateful for their help. So if we move on to the next slide. So there is, I work in Kerrymuir. Kerrymuir is about, so our practice area is about, what, 10 times the size of Dundee. It's a very rural setting. It's on the foothills of the Cairngorms, and that's where I work. And yeah, it's a great place. Next slide. So yes, we have more people who are frail who are staying at home, and if anybody is aware of the Unscheduled and Urgent Care Collaborative that was launched on the 1st of June, you might not. I wouldn't forgive you if you're not. But the upshot of that is that the high priority for the government is that we will deliver more care, which is urgent, closer to home. Now, that's a very laudable and a very good thing. But if you're not delivering it in the hospital and it's closer to home, it is primary care where it's at. So it is going to be a big focus for us going forward. And the GMS contract, as we all know, emphasises the breadth of a multidisciplinary team to support that. What does that mean exactly? What is urgent care GMS contract? Well, there will be something coming out imminently, hopefully in the next few weeks, which articulates that, but it won't be prescriptive. It will encourage you to develop a team. It will encourage you to support. It will encourage things to happen in your area, which are directly going to be evidencing broadening that team and skill set. And I'm going to show you some tools that I've been working on to help show that. Next slide, please. So, this is the primary care ecosystem. This is just to highlight, don't read it all in small detail, but it's to highlight that it's complex. This is what we've done in Tayside. We're using this for kind of SWOT analysis and things, and looking for areas of improvement in urgent care. But this was just to articulate that urgent care is primary care's business. It's a huge chunk of our work and it's complicated and we do lots of things within it. But don't worry about the slide. Hopefully you can look at it in your own time. But it's just to show that it's a complex system with lots and lots of different pathways in it. But a big chunk of it is managed within general practice, but not at all. Next slide, please. So we work really carefully with, really closely with our community nurses, our district nursing team. So certainly for us in Angus, and certainly my practice, urgent care for us is a thing that we share very closely with our district nurses because they're so skilled. It's the things that they do and the assessments that they can provide and the community care that they deliver. And so we developed a tool to try and articulate what that was. So we made a couple of investments in our district nursing team locally. We got one of them up to prescribing level. So she's a prescriber now and obviously done a clinical assessment module. And we've got another one that's done their clinical assessment module now as well. So we've now got two. And we're wanting to assess the impact of that because that's, these are patients that they were already seeing usually who had an urgent care need. But if we increase the skill of them, what impact can it have? So this tool has 3 stages. First of all, you annotate on that top line there the changes that you make. And then on the second line, you annotated the number of visit requests that came in, the number that ended up being looked on the triage, and the number that ended up actually becoming visits. What was also interesting is that the GPs themselves who are doing triage tended to generate visits from other areas. People would phone up and not necessarily say they wanted a visit, but that's what they needed. And then at the bottom, you then, for each visit you did, you annotated who did it, whether you generated a prescription, whether they were admitted to hospital, or whether they had subsequent contact with the GP or out of hours in the next 48 hours. And it took about a minute a day to do this. So this is 1 minute a day to extract this data manually. Next slide. So the data then produces into this, and this is 6 months worth of urgent care data in my practice for home visits. And this automatically populates from that thing that we just inputted on the previous slide. And this is an Excel. It's a very clever Excel, but basically that top left shows you the number of visits we do. The bottom left shows you the very bottom line is the number that were requested. The orange line is the additional ones that we create. And then that gray line at the top is the number that we ended up doing. Then in the middle section, you can change which practice group you're looking at. That's GP or specialty trainees. That's our GP registrars. Or you can select any staff group you want because we've got different staff groups that were involved in doing visits. And then on the right side, that's our 3 kind of what we call balancing measures. That's are we making changes in prescribing more? Are we making changes in having more people into hospital? Or are we making changes and there's more contact with the GP? And then we look at how that impacts on the number of visits that a GP ends up doing. And it didn't look like we were doing very much less, although it certainly felt like we were doing less. And that was after we had both a practice ANP supporting within the practice. We also got our DN prescriber and we got our band 6 DN. And if you move on to the next slide, if we just selected the DNs, the DN part of the team, we could see exactly how many prescriptions they were doing. And notably, prescribing was still something that was needed for the ones that they were seeing, But you can see on the right side of the graph there that notable jump, especially affirmed by that support of the band 5 clinical assessment DN, that we've managed to sustain a decent increase in the number of visits that our DNs are capable of doing. And as I say, this isn't necessarily extra work for them. This is often patients that they were already seeing or had already seen that morning or were having to go out to see anyway that day for another reason. So this was patients often known to them, and for which the DNs, as I say, have a lot of expertise in working out what are the other considerations for managing to keep somebody safely at home. Moving on to the next slide. Where can you get a copy of this? I will pop a link in the chat, but basically if you want that spreadsheet that lets you do all that, you can download it yourself and you can populate it yourself. And as I say, it takes about a minute a day, and I will quickly do that in the chat just now. And next slide, please. What will happen in the future? Well, if you open a vision record at the moment, EMIS, the same thing applies, but when you open vision, it's really important from here on in, from today, make sure in your practices that your GPs have a pop-up, and everyone else, your admin and your nurses as well, that they have a pop-up that lets them annotate the encounter type that they do. Encounter types are really important because if you don't put in the right encounter type when you're in vision, you end up not being able to use the data very effectively. Because if you move on to the next slide, what we're about to launch, hopefully in the coming weeks, is this. This is a little tool that will be downloadable into every practice in Scotland, EMIS and Vision, which will, at the red at the top, let you see the total number of encounters. At the blue star, you can look at it by consulter, you can look at it by individual. On the orange star, forgive me, I'm colorblind, I'm not good at colors, but on the left, you can filter it by different encounter type, and on the yellow star, you can see it as a run chart. It's still a work in progress. We're still kind of teasing little bits out that we're fixing. There's another update today that I'm piloting, which should hopefully fix a few of the quirks with it. But it's going to be really powerful. And if we use it correctly, aggregates of this data, anonymized and pulled up to board and partnership level, can be really powerful to actually articulate how much work we are doing. It's still almost there. England have got this sorted, and they have had for a few years, but it's what's hopefully going to be coming, and obviously it's slightly different to the previous thing I showed you, but it's hopefully complementary. So I'm going to hand over now to Lynn, as I say, Lynn Martin, practice manager within Tayside here, and then she'll move straight onto Anne thereafter. Keep going in the chat, guys, and I'll keep an eye out. Thank you so much.
Thank you, Scott. My slides were a little bit behind because I was in the middle of closing a practice before this all happened as well, so bear with me. So I'm with Arbroath Medical Centre. Last year we had a GP who had left the practice to head up to Aberdeen, and with the changes in COVID restrictions and things were getting a bit busier in the practice. So prior to COVID, we had discussed about having a full triage system. This was put on hold because of the pandemic. As it turned out, the pandemic ended up having a lot of telephone calls, etc., that sort of tied in with the triage. Anyhow, with all the changes last year, we decided to review this decision. So October time, we started to think we need to relook at our time management and appointment management. So we decided to put in place a full triage system. At about the same time, we were looking to put this into place in December, because as you all know, it takes ages to get appointment systems and templates and things like that changed. We heard about the access work from Health Improvement Scotland, so we took that on, and I thought, well, this might be a little good omen. There was about a bit of discussion on how to do the triage. So we have 2 advanced nurse practitioners. So instead of having a whole morning of triage for each of them, what we did was we broke it into sections. So while one is doing triage for an hour, the other one is seeing patients, and they swap over for that morning. Then they go on to other booked appointments in the afternoon. Thing with any system is you have to have appointments or places to put these patients. So that was another issue. So when we were involved with HIS, we developed systems. Oh, sorry. Can we go to the next slide, please? Sorry. we developed systems for the data gathering. So along with this, they could develop their own charts, but they needed to know how we were going to put the information into that. So we used the system utilities appointment reporting system on the app's controller module within Vision. We tweaked the run charts to suit ourselves. Initially, we were running these reports 3 times a day, then went down to twice a day, just to get a feel for how the appointments were being used up throughout the day. As it says on the screen, we noted on the run chart any tweaks made to the triage system to allow us to show if these tweaks changed any appointment supply. So for instance, if doctors were on holiday or an ANP was on holiday, it might make a difference. We were planning to do the sort of spot check ongoing once a week review of this, but due to sickness, COVID illness, bereavement leave, you name it, that just didn't happen. Can we go to the next slide, please? So that I don't know if anybody has actually used the appointment reporting in Vision, but that was just a screenshot to show where we were finding the information. Next, thank you. We did find that the run chart was very useful. As I said earlier, triaging, like all systems, works when all staff are in. The problems arise when there's staff on leave or sick, and we did have an extended period, sort of March, April time, when we had a GP off over and above the school holidays and things, so that made it a little bit difficult. The run chart, though, was very useful to in the early days to look at this, and I think if we get back into the monitoring of it, I think it would be even more useful going forward, taking into account what Scott's just said about the consultations. We might re-look at how we monitor this. Anyhow, again, there have been challenges, as we all know, with the restrictions further changing. There's even more demand from patients, and with the shortage of GPs, etc., it's not really helping. You always need another appointment to put it to, and if there's a lot of review appointments getting booked into the GPs, then what we have to do is manage the ratio of booking ahead appointments compared to on the day. Some things go straight into a face-to-face rather than being triaged. So for instance, breast lumps, there's no point in them having a telephone and then a face-to-face. So sometimes when you've got shortages, it's good to have extra locum cover, but then sometimes that still leaves a lot of work left for the partners to do. Next slide. Again, this was just an extract of the run chart that we had. Not nearly as complex as Scott's, but it did the job for us. Next slide, yep. The practice plans to review the triage system as of this week. We're having a meeting. Part of that is, as I just said, about the demand changing. We've also taken a large amount of patients from the practice I've just been involved in the closure of. So our list sizes went up by about just over 900 overnight. That's in a local village, so we're looking to provide a satellite service there, because again, when we were talking earlier about equality and to access, then having to travel 7+ miles for a practice or indeed more, then we felt that we wanted to provide something for the patients that were taken over by us. So with that in mind, we do need to have more of a look at what's happened. We also have another GP retirement coming up later in the year. We've still not replaced for the GP who left us last year. So as ever in general practice, there's always a challenge, and we just have to try and meet that. But certainly for other projects, I think we would use the run chart and amend the headings and things to fit our needs in the future. And that's me. Thank you very much, and I think it's over to Anne now, unless you've got any questions.
Hello, can you hear me? I think hopefully you can all hear me now. Yep, thumbs up, that's good. Yeah, I was introduced, my name's Anne Reeby. It says practice manager here. I'm actually retired practice manager. I worked for 20 years as a practice manager and then went into primary care development with NHS Shetland Health Board. And now every now and again, they take me out the cupboard, dust me off, and I do some practice manager cover and also some dispensing cover. So I'm still back in the practices. Could I next slide, please? I live and work in Shetland. We're all EMIS practices in Shetland. And in November 2021, I was covering for, so I'm just going to set my timer so I know what I'm doing. I was covering for a practice manager in the ELL Centre, which is a small remote rural dispensing practice with a population of about 990, nearly 1,000. And we were approached by HIS to look at areas of understanding clinical demand and try and identify an area which the practice team felt needed maybe a different or improved approach to understand the demands of the clinical time. And while we're a small rural practice, the team thought about it, and generally we're fortunate enough to say that capacity and demand are usually fairly well matched, and most patients were able to get appointments on the day they wanted them or a future appointment. So the practice themselves didn't see that as being a problem. So HIS wanted to look at a snapshot, do a bit of rapid data collection and analysis using data collection tools to look at some area of demand. And practice at first, a wee bit resistant rather to taking on something at that time of year, coming up to Christmas, a busy time, more data collection. It's not always a number one hit for admin staff, but persuaded them that it was only going to be, there's only 3 very simple steps. This was a very small exercise we were doing. So the first thing, next slide, please, that we did was we asked the team, well, if it's not around demand and capacity and patients getting appointments, what's the other demand in GP times? So we sat down and we sought their subjective views, because admin staff are usually the best at identifying, and practice managers, what's going on. We asked for their suggestions, and they did agree on a topic. Next slide, please. Yeah. So what they decided to focus on was unseen demand, because GPs, as you know, although we had a busy surgeries, usually fully booked, then sometimes, well, often, very often, they come back at the end of the day, and there would be a huge amount of admin work in the form of dot man, or in our case, tasks, which is part of the EMIS system. So these tasks are sent to GPs regarding different categories of patient queries, and that can increase the workload substantially. So the practice decided some data collection to identify the number and type of tasks dealt with on a daily basis by GPs would be a good way to look. So next slide, please. So what did we do? Well, this was, as I say, this was not as complex as some of the other data collection that you've just been viewing, but HIS kindly produced some data capture tally sheets listing we had 12 categories of tasks being sent to the GPs, and these data capture sheets were given to each reception desk, one in the morning and one for the afternoon. So we had a brief session with the staff just to go over the process of what we wanted to do. It's very simple tally sheet and gate charts. Next slide, please. So once they'd done that for just a week, and I have to say that when they were doing it, they actually said it wasn't too onerous. They found it not bad at all. So once they'd done it, the practice manager collated the daily counts onto a spreadsheet, which was then sent to HIS, and who analysed the demands of the various tasks at the end of the week. Next slide, please. So this data collection sheet. It's a special Excel dashboard, so it gives you an interactive display, you know, with Pareto charts and graphs, and it highlighted which categories generated the highest and lowest number of GP tasks, and you could use the buttons along the top to see what the demand was in a day or over a week, which was quite useful. Next slide, please. So what we learned was that the majority of tasks were for repeat requests for repeat acute or reauthorised prescriptions. It was mainly to do with pharmacy. We learned that there was some scope for signposting to local pharmacy and using pharmacy first. And also we noted that many of the task categories were historical. I think had been in there since got EMIS, and they weren't used, and there was some not in there that we needed. So there was also some differences in interpretation and urgency and the perceptions of categories. So some could cause delay if they weren't correctly classified. Last slide, please. So what we decided was some of the findings, you know, we knew already that the pharmacy was a big one, and the practice doesn't currently have a pharmacy. So we used some of the information to send to the local prescribing advisor. And I've now heard that hopefully in July we're going to get some pharmacy input. So thought a good exercise would be to repeat that collection once the pharmacists and post staff actually thought that they would have liked longer to do the exercise, because the week before Christmas was a bit of a different week. They were going to review the list of categories and take out ones that shouldn't be there and maybe add some more in, and do a little bit of staff training around this, because it had been a while, and sometimes just your assumption that everybody's doing the right thing, you sometimes just need to revisit these things. And we felt engagement with local pharmacy around telephone consults and near me consults for pharmacy first promotion, because we don't have a pharmacy on the island. So phone calls or near me consults would be much better. And that was our findings. So that's me, and I think we're back to the discussion.
Thanks so much. Yeah, thank you. My teeth back in. Thank you so much, Anne. That was really much appreciated, and thank you, Lynn, as well. Without dwelling on the detail of each of those presentations, I guess what we're all showing is that you know, that taking the time in data to actually utilize that to drive access conversations and improvement is not a bad thing. It's certainly not the be all and end all. And I think in the first section of our webinar today, you know, the information shared from Kate across and Rebecca about the involvement in the PPG in that as well, but also how to usefully engage your practices in access conversations is really important. I think if you're still doing the same things as you were in the pandemic or pre-pandemic, what have we learned? And I think it's important to reflect upon what have been the opportunities that the pandemic has shown. And I think it was really interesting in the chat. I feel the breadth of the variation, but also the willingness to want to learn about other different bits of this. Everybody has subtly different issues, but there's so much similarity here about the different things that people are facing, but also the different things that people are doing to tackle it. I think if you're not doing anything at all, I think it's going to be really difficult to justify, because there's definitely ways that things can adapt and improve. There are definitely tools out there that HIS have really been at the forefront to support, to try and develop for us. But these tools are obviously all on the HIS website in the access area, where you can try them. And if you need support for this, your local list team might be helpful. Also, your improvement advisors within your primary care settings, hopefully you have some. And if you don't, it's definitely something you should be promoting, because your cluster should have access to improvement advice in order to help. And whether that's at a board level or a partnership level, I'd strongly encourage you to utilise that. we're oddly ahead of time, which is really good, and it's not common for us. But Michelle, I was just going to check before we headed off whether you had any last-minute messages before I hand across to April for our final summing up, Michelle. But what an invigorating set of discussions, I think, and showing how much work we're all doing. Access, we're not sitting on our bottoms in general practice and primary care at all. And I really, really look forward, if we can get that encounters data correct, you know, how powerful is it to say to the Cabinet Secretary, do you know that, you know, last week, I don't know, 50,000 people across Scotland spoke to a pharmacist from their practice to discuss their medication. Did you know that, I don't know, 60,000 saw their own GP in a home visit at their own home? So these are really powerful numbers that we've never, ever been able to show and to articulate. The numbers will be bigger than that, and not even in a week. I mean, in a week in Tayside, I think we're looking at something like 12,000 home visits. Across Scotland, what's that, 120,000 home visits every week in Scotland? These are powerful numbers that have been hidden from the rest of the system, and I really look forward to being able to, the power of being able to show what we do and then track it and look to improve it will be really important, and the impact of the GMS contract on that as well for that broader team supporting us. Michelle, anything before? I've got a minute to go before I have to hand over to April.
Yeah, you know, for me, it's really important to recognise that there's lots of things we could be doing, but the thing that's shining out, particularly from the chat bar and from our speakers today, is that people really care about this. You know, we want to get it right, and there are some things that we can and should be doing once for Scotland. So some really interesting comments in the chat bar around the technology-enabled part of it. You know, should we all be having our own personal laptops, the ability to get onto dual screens and promote much more flexible working? Do we have to you know, consult in the way that we've always done? Well, no, there are lots of options. How we communicate with the public and our patients is, you know, an age-old argument. I've been around for about 30 years and it's not changed much, but how do we make sure that we value things? And part of that is we've got to learn to value ourselves as a profession and as a wider multidisciplinary team. And how do we get that message across? And one of the ways, as you're rightly pointing out, Scott, is to collect that data and information and show people just how much is happening. And the other thing I'll just leave you with is, you know, we know more than 90% of everything that happens in the NHS in Scotland begins and ends every single day in primary and community care. It's nowhere near acute hospitals. Tiny shifts in that have massive impacts onto the rest of the system. And if we can help to demonstrate that a bit more, then I think we'll be able to put ourselves in a much more sustainable position going forward to the future. The most important thing is we do it together. Thank you.
Thank you both so much. That I really enjoyed that session. I think the chat said was just going like the clappers, wasn't it? It was full on. I could barely keep up. So I think my takeaway from today is really just around the importance of listening and capturing that information. We heard about listening to patients' voices. We heard about listening to staff and listening to that data and what that data is telling us, and the importance, as Scott underlined, about collecting that data so that we can use it to make a case or to build on our learning. So I think that is absolutely crucial. A brilliant session, if I do say so, and thanks very much to everybody that's been involved. We'll move on to the next slide, please. So we do have a couple of wee things for, to pick up on before you head off. The first one is our evaluation. And we do like to do this, obviously, as improvers. We want to know what we could do better. And also this helps us to identify what topics we want to cover in our next and our upcoming sessions. Our next webinar will likely take place in the autumn. So this will give you a chance to say what you would like to be covered in that. And also, we just want to point out, a couple of people asked in the chat, we will send out an email with a link to the recording and any links that have been mentioned today. It does take us a little while to do that because we tidy it up and put in closed captioning and things like that. So bear with us while the team does that. In the meantime, if there's anybody that wants to get in touch, if there's anything that we covered that we maybe didn't share that you would like to have access to, please do contact us either via our website or Twitter or on our team email. And then next slide, please. It just finally remains for me to say thank you so much to everybody that dialed in, that engaged in that very, very busy chat box. Very importantly to our speakers today and our two chairs, and also to the people who made this all happen and come off without a hitch. Behind the scenes, there's a lot, as you can imagine, that goes on to working up one of these webinars. So thanks to the team that's done that as well. So thank you all very much, and we will see you very soon. Take care.